Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Workplace Culture and Patient Safety. Following the webinar, please be sure to follow the instructions alongside the webinar's link on the NCAP website. NCAP members will receive 1 hour of free North Carolina CE credit. Our speaker today is Bob Cisneros. Dr. Cisneros came from a pharmacy family. Both his parents and grandfathers were pharmacists. He attended pharmacy school at the Northeast Louisiana University, which is now the University of Louisiana at Monroe. Completed a hospital pharmacy residency at UAB, where he practiced in Birmingham for 17 years as a hospital pharmacist and obtained his PhD from Auburn University. Dr. Cisneros became a faculty member at Campbell University in 2003, where he continues to practice. He was an academic fellowship participated in the Academic Fellowship Leadership Program for ACCP 2011-2012, and was National Advisor of the Year in 2007 for the Phi Delta Chi Pharmacy Fraternity. He teaches courses in healthcare systems, management, and medication errors. I'll hand it over to you now.
Okay, thank you very much, Amy. I appreciate the introduction. Although I might mention the AACP might get mad, but it was a fellowship program for the AACP, not the ACCP, but that's okay. But I'm really happy to present this program, especially on a topic that I have a real interest in, which is in the area of patient safety and medication errors and workplace culture. I think what we'll talk about will apply to any pharmacy organization. My background is hospital pharmacy, but I think you find the things we talk about are pretty applicable to any organization, much less an independent pharmacy or a hospital pharmacy. There are several objectives for the program. I'll just go through them pretty quickly. One is we're going to talk about some of the different types of workplace cultures. So one objective is to describe at least 2 characteristics of the 3 different types of workplace cultures we'll talk about. Discuss how poor management or supervisory skills impact patient safety. List 2 desirable supervisory behaviors. Describe the impact of intimidation on patient safety. Explain the SBAR and CUS communication methods, and these are acronyms for methods that we'll go over. List areas of evaluation and a root cause analysis. Okay. What interests me about patient safety really has to do with things that we're going to talk about today. In my experience, many of the difficulties and problems and errors that I saw and experienced many of them were related to exactly the things that we're going to talk about. Okay, what is workplace culture? I mean, a very academic description is that it's the character and personality of your organization. It makes the organization unique. And really, when you think about it, it's really the sum total of the beliefs, behaviors, the attitudes of everyone in the organization. I bet you we'd agree that even though we've probably worked in multiple pharmacies, each pharmacy was not the same. And each pharmacy had its own unique, distinct atmosphere. A positive workplace culture offers a lot of advantages and is probably the safest place to work. If you look on the right, there was a survey that was discussed on LinkedIn, and you should be able to see the URL where I got this from, and that it mentions that most professionals today would not work at a leading company if it meant they had to tolerate bad workplace culture. 70% of the people agreed on this. In my experience, when people have changed jobs and left an organization, sure, sometimes it was because of an opportunity for more responsibility, a better title, but most of the time for people I know who left, it was because they just couldn't stand where they worked. Maybe it was the management, the administration, the safety of working in an environment where they felt pressured and maybe more likely to make mistakes. But there's no doubt that a positive workplace culture certainly affects your happiness. It attracts talent, a workplace that's good to work in, with a good administration and leadership and management, word gets around. That's where people want to work. It also drives engagement in that if you're happy where you work, you want to be involved. It drives you to do the best you can. So obviously it impacts happiness, satisfaction, and definitely affects performance. Now, as I mentioned, most all of us have worked in more than one pharmacy. And even though there's State Board of Pharmacy rules and federal rules that don't change, probably things were different in each of the pharmacies we worked at. And here's just some examples. Maybe you've worked in a pharmacy where you could play any music you wanted during a shift. In other pharmacies, it was frowned on to play music. What about a dress code? Not all the pharmacies are alike. Some have a pretty informal dress code. Maybe in others, you really had to dress up a little bit. Blue jeans weren't acceptable. What about unwritten rules and policies that you don't see in a policy manual? I worked at one pharmacy where after a day of orientation, I was asked to tag along with another pharmacist there for a few days, and one of the first things he told me was, "Now I'll tell you how we really do things." When to take breaks, I can vividly recall one day working in an IV room and suddenly hearing a lot of screaming, and it was two technicians shouting at each other about who could go on breaks first. And that can be different from pharmacy to pharmacy. Holiday schedules, weekend schedules, and the management style. Maybe you've worked with managers or pharmacy directors that were hands-on, almost too much hands-on, and others that were very laid back. What about jokes? I've worked in one place where it was frowned on to date other people in the workplace. And with jokes, one has to be careful. I've given enough lectures on sexual harassment and discrimination to know that in the workplace, to say that, well, a new employee just has to, get used to the way we treat people, that doesn't cut it anymore and could place a pharmacy in jeopardy. Well, if you look it up, in most academic literature, in management textbooks, a couple of different types of workplace cultures are described. One, which probably is really not the most desirable one, is often called the pathological culture. It's characterized by being very power-oriented, very low cooperation among people, scapegoating, and oftentimes there's an I don't want to know attitude. When employees see something wrong and want to bring it up, it's almost as if the leadership just doesn't want to know about it. And it's often said that messengers are shot. Now, I don't know if this will ring a bell, but have you ever been in a meeting or a classroom where when one particular person raises their hand, everybody's eyes roll and you hear a lot of anguish cries like, "Please don't ask a question"? Well, I can tell you that oftentimes it's that person that often brings up the most significant ideas. And if that person is treated poorly because they are asking questions, they're bringing up concerns, other people in the room or other people in the organization will see that, and many will be dissuaded from bringing up problems and confusion. That's why the phrase "messengers are shot" is often used. And as you can see from the picture, see no evil, hear no evil, speak no evil often is a characteristic of the organization. Another organization is often, or another culture is often described as a bureaucratic culture. I put Post-it notes there. Have you ever walked into a pharmacy or an office on a Monday morning and found lots of Post-it notes about things, warnings, cautions to do things a certain way? Well, this is a type of culture often called the bureaucratic culture, in which concerns and problems are Post-it notes, but nobody makes the effort to go and fix the heart of the problem. Repairs are quick fixes, not systematic. So you may see posts about products looking alike, for example. Be careful, don't confuse two particular drugs. But nobody really makes an effort to to do something about the way they're stored. Additional warnings. Perhaps a computer system can be helpful when those drugs are entered into a computer to flash some type of warning. You know, post-it notes just stay post-it notes. In fact, this cartoon kind of describes a little bit of what I've been talking about. If you see in the top one, there's leaks in the dam. And it's very difficult. All you're doing is patching one leak, patching another leak, and apparently nobody is making an effort to really fix the heart of the problem and repair the dam. It's kind of like running around with Flex Seal, trying to cover all the holes. And it's not going to work, because sooner or later, you just can't cover them all. In fact, what's interesting is the ISMP a few years ago produced this diagram, and it depicts the error reduction strategy and the sticking power of the strategy. Now, if you look at the bottom under low, it lists education, information, and suggestions to be more careful and vigilant. Now, that may seem pretty odd. It doesn't mean that these aren't important. But the point is, well, for example, consider a sermon on Sunday. I'm sure a lot of us would agree that there are a lot of sermons that we can't remember 48 hours later. And probably the best of sermons are ones that you remember, you can take a few pearls from, apply it to your own life, apply it to the way you treat people. But otherwise, it may just be forgotten. The same thing, but even with CE programs and documentaries you may see, and somebody flashing a finger urging people to be more careful. These are important, but if nothing else happens, they just remain things you've heard, sermons you may have heard, but didn't have anything to act on. If you go up the ladder, you'll see that the additional things written, the additional strategies, are things to do, actions to take. They go beyond just recommendations and suggestions. And I would hope that there'll be at least a few things that you hear in this program that spur you on to do something. Otherwise, it will just remain a CE program, you get an hour credit. But I hope there's more to it than that. In fact, as you go up the ladder to the high sticking power, you notice, for example, it includes building redundancies into a system. So if something does go wrong, it won't get to the patient. There's a backup. Standardization. I wonder how many types of magic mouthwash formula there are. Well, standardization can help reduce the possibilities that things are going to get mixed up. It could be, we could use magic mouthwash as an example, or what about heparin drips in hospitals? I worked at one hospital years ago where basically a physician could just about order any concentration that they wanted to. But fortunately, wiser heads prevailed, and the number of possible concentrations was reduced to just perhaps 2. Automation, forcing functions, fail-safe things, storing medications that are a problem in a way that you reduce significantly the chances that they'll be mixed up with anything. So the important thing is to hopefully see the pearls, see things that you think are really applicable, and put them to use. The ideal culture is sometimes called a generative culture, where problems are actively sought, okay? Problems are actively sought, and when failure occurs, failure leads to inquiry. In other words, nobody ignores the failures. Nobody, it's not the see no evil, hear no evil, speak no evil type of workplace. People that have problems, that raise their hands, that want to ask questions, that want to bring up concerns, they're rewarded. New ideas are welcome. And when things go wrong, it leads to change. There was a study done in business leaders at a meeting. They divided up all the business leaders into groups that were sitting at a table. What they didn't know was that a couple of the tables, maybe half of them, they planted someone who was going to be that pain in the neck person who would raise their hand and question things and drag on the conversation. Each group had to solve a problem. At the end, can you guess which groups had the best solutions? It was the one with that pain in the neck person that was, you typically associate with raising their hands and asking questions. It wasn't that long ago where talking about errors was frowned upon. Fortunately, today, it's much, much different. And hopefully, in all our workplaces, we feel comfortable talking about errors and thinking out loud about how to prevent them. I'm a reviewer for the ISMP, one of, I'm sure, many, many, many reviewers. But I know Michael Cohen once told me that when he and Neil Davis began writing a column in the journal Hospital Pharmacy many years ago, they often received some irate letters from physicians and hospital administrators and pharmacy directors, because it was like they were revealing a secret by talking about errors, even anonymously. Today, I think it's a much better atmosphere. To not talk about errors, to not know what's going wrong, is much like a miner going into a mine without that little light on the helmet. If you don't know what's going on, how can you not make a mistake? When you don't know what errors are happening, how can you prevent them? Management and supervision sometimes are not really associated with medication errors. You don't see too many programs related to the importance of supervisory skills or management skills. Matt Grissinger wrote an article, and the link is there on the screen, dealing with this topic, and the title of the article was "Supervision is Often a Weak Link in Error Prevention." And it truly is. And I'll give you an example. I teach an elective on medication errors here at Campbell, and more often than not, one question I ask in the class is, have you ever worked with in a pharmacy, or have you ever worked with a pharmacist whom you just knew was not really checking your work closely? And there's always hands that go up. So supervising and managing is something that these skills are important. Even if you're not one with the title of manager or supervisor, my feeling is that all pharmacists have to have good management and supervisory skills. If you think about it, all pharmacists are managing the technician they might work closely with. You'll have students and other personnel in the pharmacy. So these skills are important even if one doesn't have the title. So in the article, which is not a long article, he talked about some of the skills which were felt to be very important for someone who wanted to be an effective supervisor. I'll just mention a couple. You can see them. Helping to establish a climate of excellence. Ability to work with people, not just telling people what to do. Holding workers accountable and making employees feel involved and important. Getting people to work together as a group. Now, there are several more. Two I wanted to mention in particular are making sure reasons why something is done are clearly stated and providing sufficiently detailed answers to questions. I can remember once I was working with a technician and I was checking the medication cart that the technician had set, and there were a few things wrong, and I would point out in a very nice, friendly way the things that the technician might have done wrong. And the technician looked at me and really, and I'm paraphrasing, but basically said, well, isn't your job to catch these things, so why tell me about it? I think it's certainly mandatory for a safe workplace to have really an ideal culture for everyone to know when something goes wrong, for everyone to understand their responsibility. And when something is done, people need to know the reasons why something should be done in a certain way. I can recall in a pharmacy where a labor and delivery called one day to the IV room needing a medicine, and the technician just kind of put it on the side, didn't realize they needed it like right away. And all of a sudden there were frantic phone calls from labor and delivery. And the reason is the technician had never been trained properly and just didn't know that what was being asked for was something really important. You know, providing detailed answers to questions, I think, is significant, just as much. I think when I first started practicing pharmacy, when I found something wrong, I tended to just correct it myself because it was quicker, and if I stopped and started to explain to someone what went wrong, it would take too long. But it didn't take long for me to realize that for me to do that and not actually go back to the person who made the error at some point and actually explain to them what went wrong would take me twice as long over in the long term. And I think in a really good culture in the workplace, that kind of attitude is predominant. When something's not right, take the time. It may not be, you know, you may not have time right away to do it, but certainly in a short period of time, explain to somebody what they did wrong so they'll understand the significance of it. Notice adjusting one's supervisory level style to accommodate differences. This is often called situational leadership. Don Blanchard wrote a book about it. It doesn't mean you're changing your ethical style. But basically it means you're adjusting your supervisory or management style to accommodate people based on the level of complexity of the task and the experience of the person. A high school student who's never worked in a pharmacy before, you know, may need a lot more supervision. This is a case where really micromanagement may be good and helpful, at least initially. A technician who's worked for 20 years with a truckload of experience, if you tried the same management style or supervisory style, might get really angry. So being flexible enough to adjust one's style is important too. And I would refer you to the article to see more detailed information. The article also mentions some research that was done. Professionals who rated supervisors as pretty poorly, meaning they were low on supervisory or interpersonal skills or were very autocratic or punitive. These professionals ended up making more mistakes, significantly less satisfied with their jobs, and less productive. And it just goes back to the original point of the article, is that everyone really needs to have some good basic management skills and supervisory skills. Most of the time, this isn't brought up very much in conversations about patient safety and medication errors. But it really ought to be part of the pharmacy culture in an organization because it is so important. And I don't have time really to show videos in this program, but I am providing links, and I hope you will take a little bit of time afterwards to look at them. Personal example is one of the best ways in helping to produce an ideal culture in the workplace. Everyone taking the responsibility on their own to treat people right, to speak up when speaking up is necessary. This link is kind of a funny link, and I'll just briefly tell you about it. It's about two monkeys. You'll see two monkeys in the middle of research. One is being fed a cucumber, one's being fed a grape. The grape, obviously, is the tastier one. Well, after the monkey who's been getting the cucumber sees the one with the grape, he ends up taking his cucumber and throwing it at the researcher. Bottom line is, everyone notices how everyone else is treated. Everyone notices how we work and act. If we're in the workplace and we preach safety and we get on people for making mistakes, we need to be sure that we're being the role model, that when they look at us, they're seeing what we preach. Otherwise, they're not going to respect it, and it's going to go in one ear and out the other ear. Personal example is critical. Many people, I'm sure, have been in situations where they felt intimidated by someone in the workplace. Gus Lee, a graduate of West Point, in his book called Courage, the Backbone of Leadership, says, no matter who we are and what we do, we are seduced by avoidance. The easiest thing is to avoid. The ISMP conducted a series of surveys which they've called the intimidation surveys. And I just wanted to go over a few things with you. They're freely available on the internet. I've provided a link. This is one of the tables. And I've circled a couple of things, and I think they're very interesting. The question that was asked, for example, in the first circle is, have you ever assumed an order is correct rather than interact with a particular prescriber over the last year? In 2003, 39% of the professionals said yes, they had. In 2013, it went down a little bit. But what still is bothersome is that that's about a third of the folks that were surveyed who said that even though they thought something perhaps was wrong with an order, they assumed it was correct so they wouldn't have to interact with someone. Maybe a physician who's been rude and crude, or someone else. And this to me is shocking. The culture of the workplace should be one where people aren't afraid to step up, try to correct things that are correctable, and they should know that in the workplace, they're supported in doing this. If you go down a little bit, actually the second in the table there, I don't have it circled, is assume order is safe because of the stellar reputation of the prescriber. 34%, and in 2013 it was 30%. Still, almost a third are assuming something is safe, even though they may still question it, but because of who wrote the order, they're going to let it fly. Bottom of that, at the second circle, felt pressure to accept an order, dispense a product, or administer a drug despite concerns about safety. 49% in 2013 or 2003, and in 2013, 39%. It went down, but still succumbing to pressure. As you go down the list there, you see at the bottom, I am aware of a medication error in the past where disrespectful behavior played a role. 7% in 11, at least once. Now, notice the column that has often. That means it happened more than 10 times in the previous year. But in the workplace, intimidation can be a powerful tool, a powerful negative tool. And I think ideally the culture of the workplace should address intimidation, should address disrespectful behavior. That should be talked about. The culture of any organization should be to do what's right, especially in healthcare, and not to be afraid to speak up. The ISMP in that same article also had a list of disrespectful behaviors that were reported. I'm sure, unfortunately, some of us can relate to some of these happening to us. Negative comments, impatience, hanging up a phone, etc. It's important to realize intimidation can take place even within a department, not just outside of the department with, for example, physicians or physicians' offices. When it happens, either inside or outside, it needs to be addressed, even though the easiest thing to do is avoid it. Now, how do you address disrespectful behavior? This is part of the culture of a workplace. What can you do? I think in a more organized setting, sometimes hospitals have different committees to specifically address disrespectful behavior. They have a code of conduct. I know in the community pharmacy setting, it may, at least when the disrespect comes from outside the environment, it may be more difficult because there's not such an organized structure of the medical staff, for example. But still, we need to speak up. We need to say something, regardless of whether it's inside or outside the workplace. I've heard different recommendations on how to do this. One has to do with the different boards of medicine and pharmacy. To complain. We don't just have to sit there and take it. One call may not solve a problem, but when multiple calls take place, it's more likely that people will start paying attention. We're going to talk a little bit more about how to address disrespectful behavior. Now, sometimes when problems develop, it's often because of the messenger and not really the message. The way people communicate can be a source of friction and lead to problems. And I think everyone in the workplace should be familiar with the appropriate ways to address a question to someone. I mentioned two acronyms, and the objective, SBAR, is one. Many of you may already be familiar with it, but it's just suggestions on how to communicate. And basically what the acronym means is, for example, if you want to question an order or medication dosage, when you're communicating with someone, provide the situation and background, then give your assessment and provide recommendations on changing the dose, if such is the case. But it's an organized, structured way. Certainly when someone wants to get something changed and doesn't have any recommendations in mind, I think that person loses respect, and probably it's less likely that anything will change. So SBAR is, again, a communication method that really describes providing the situation and background, giving an assessment, and providing a recommendation. I've provided some links to some very short videos that I think would be really helpful that demonstrate how SBAR really works. They're short videos, and I hope you take the time to look at them. One or two show good ways, and the third one, excuse me, shows a poor way of doing it between a nurse and a physician. CUS, which is another acronym, is slightly different. There's a link, some links there, which can give you an actual example from a short video. But it basically recommends words to use when communicating. If you think something is unsafe, use that word. In fact, the order in which it's recommended to use these words are express your concern. If nobody's listening, go to the next step and say your word because whatever the issue is, you think it's unsafe. The next step is to really talk about that you're scared, you're really concerned. And hopefully this will at least convey your concern. I think the important thing when communicating is to make sure you're communicating that you think this is a problem. People need to be able to hear it and or see it in your actions on your face that you think something can be very dangerous. Oops, I think now, the Agency for Healthcare Research and Quality, the acronym is AHRQ, has conducted research dealing specifically with cultures in the workplace. They've conducted one dealing with hospitals culture. That link will take you to a general website, but I wanted to show you some of the actual questions. That link will take you to the exactly what you see. It's freely available to the public. And I think some of the questions or the statements there will give you an even better idea of what a culture is about, and in particular what a culture of safety is about. Again, this wasn't specific for pharmacy, but for the hospital unit in general. But you can see some of the statements, which all of them relate to the culture. Mistakes have led to positive changes here. The staff feel like the mistakes are held against them. Patient safety is never sacrificed to get more work done. These questions may be good questions to use in your own organization to take a picture of the culture, the safety culture within your organization. Or perhaps you can use it to do your own survey. Here's some additional subjects in the study or in the survey. For example, dealing with your supervisor. My supervisor manager says a good word when he or she sees a job done according to established safety procedures. My supervisor overlooks patient safety problems that happen over and over, and so forth. And several statements regarding communications. These are also ideal things to talk about even at staff meetings. I think staff meetings, in my experience, turn out to be just announcement sessions. But I think staff meetings can be very, very valuable in talking about important issues, and in particular, important issues related to safety in the workplace. And some of these questions and some of the surveys that you'll have access to can help do that and generate some good discussion, some openness, so people can really speak up and share their mind. There is a survey related more specifically to pharmacy. I've included the link, and here's a section of it. Again, this is freely available on the internet, and where you see pharmacy survey questions, that's actually a link to a website. If you go through this, the pharmacy is well organized. Technicians receive the training they need to do their jobs. The pharmacy is free of clutter. Staff work together as an effective team. This all relates to the culture of the workplace. Some additional topics, staff ideas and suggestions are valued, and so on down the list. And I think, I'll just repeat what I said before, I think the statements on here are very good topics, either to do, for one, to do one's own survey in your own workplace, or even just topics for discussion at a staff meeting, for example. Not speaking up can have catastrophic results. Not speaking up can lead to arguments, and I think patient safety is influenced by this. Oftentimes when speaking up about an issue or saying that there's a problem, it generates arguments. Anytime one's in a discussion like that, I think the most important thing is to focus on the patient or the problem. Once discussions start to get personal, people have a knee-jerk defense mechanism that goes into play. And that's when an argument starts to drift away from the real point of the argument. The emphasis should be on the patient and the problem. We should always be respectful. But when speaking up, one always needs to be very clear about potential problems and very factual and do one's homework. And of course, have all the information you may need. I wanted to share with you some confrontations that actually this is available on the website of the Institute for Healthcare Improvement. There's a video there which actually has a medical resident, or actually it was a medical intern speaking up. And in both cases, and I'll share these with you, the bottom line was people were afraid to speak up. With the medical intern, he was told by his attending physician, who was very intimidating, that he had to go draw a blood gas from a patient. Now, I don't know if everyone has seen a blood gas being drawn. The ones I've seen where the needle goes straight into the wrist looks very uncomfortable. And this medical intern explained he really had never been trained to do it, had never done it before, but the physician was so intimidating, he was afraid to speak up. So he went and did it, caused the patient a great deal of pain. And he said he regretted to the day that he did it, and he went back to the patient and apologized. In another case, a nurse in surgery, after the surgery was over, did a sponge count, and it was 1 off. and she told the surgeon, look, we're still one short. It looks like you may, we have to go back in and get one more. And the surgeon, again, very intimidating type of surgeon, basically told the nurse, no, I've been counting. We've got them all. I'm closing. The nurse really didn't speak up after that. And what happened was the patient ended up back in surgery 2 or 3 days later because, indeed, they left a sponge in. So in both cases, failure to speak up really led to problems. And I can give you a very real example. Oh, I'll go back. In the medication error class I teach, a student several years ago talked about she was working in a hospital in a different state, happened to glance into the IV room. She wasn't working in the IV room that day, but noticed the technician was very busily adding large syringes into an empty IV bag. She thought that was odd, and by the end of the day, they knew what had happened. The pharmacist, who was a new pharmacist, had gotten an order to add 1 ampule, or 50 milliliters of sodium bicarbonate, into a liter of normal saline, 0.9% sodium chloride. Well, something got twisted around, and she had the technician fill an empty IV bag with a liter of sodium bicarb, which meant that the technician was pumping in, 20, 50 milliliter syringes of sodium bicarb into an IV bag. The end result was that it got sent to the floor and the patient died. The student in class really had a pretty good evaluation of what had happened without any prompting from me. She thought that the technician, who looked concerned, actually felt intimidated, that she was only a technician and shouldn't be questioning the pharmacist. The pharmacist, our student felt, was new and was nervous about asking for help if she was confused about the order. The end result was the patient got the wrong medication and died. Every culture, a good culture, really should be one in which a technician shouldn't be afraid to speak up or ask for help. And a pharmacist, for sure, should never feel that they aren't supposed to ask for help if they need it. And I think maybe those are really good example of what can happen if the culture is not what it should be in a pharmacy organization, whether it's hospital, community, or nursing home or otherwise. Disrespectful behavior can often generate intimidation, which in turn can generate safety issues. As I mentioned before, when we see disrespectful behavior occurring, whether it's inside or outside our environment, we need to establish interventions. In some hospitals, perhaps, there are a standard process to deal with disrespectful behavior. And those of you who work in hospitals probably would know that better than anyone else. Some hospitals may have a committee, as we mentioned before. In community pharmacy, it may be more difficult. But certainly, anyone with any management or supervisory responsibilities should be trained to step in and know how to deal with behavior like that. The culture of the organization should be one in which disrespectful behavior would not be tolerated. Intimidation should not cause one to not follow procedures. Intimidation or any type of disrespectful behavior should not lead to someone compromising a patient's safety. The staff needs to know how to deal with this. It shouldn't be something that comes up now and then when there's a problem. It should be part of the training of any pharmacist or technician. So reporting, when bad things happen like this, it should be reported because ideally you want a positive environment in the workplace, not one which can be contaminated, such as this. So we need to, report errors and hazardous conditions, and I would certainly think disrespectful behavior and intimidation would constitute a hazardous condition in the workplace. In particular, in relation to medication errors, there should not be any reprisals for reporting errors. Too often in the workplace, someone may be afraid because of the results of reporting errors. But information really should flow freely in an organization. One thing that's often missed, we can talk about errors, but how often do you hear people talk about the good catches in the workplace, where someone prevented an error, or someone caught a dangerous drug interaction? You rarely do. And I think that would be an important component that would improve the safety culture of an organization. Start recognizing the good things and not just the bad things. And near misses. Near misses are good learning tools. And by near miss, I mean an error that never reached the patient because it was caught. And sometimes we dismiss them as a result of the fact that it never reached the patient. But oftentimes, these are great learning tools to talk about because the next time, it may not be caught. Staff meetings are a great place to discuss safety issues and create the type of environment that hopefully would be supported, that would support all the employees and the staff. The ISMP, and I'm going to go forward a little bit, I hope many of you have access to the ISMP's medication error newsletter. The newsletter that goes to the acute care or hospitals, I know I'm one of the reviewers for. There's another one that's more specific for community pharmacy. But quarterly, included in the newsletter is what is called the action agenda. And it includes topics that would be great topics for discussion at staff meetings and great topics for any safety committees to consider on some regular basis. And I'll give an example. And the first problem here at the top has to do with the dosing of oral methotrexate. And unfortunately, there are serious errors that have occurred because, for example, when methotrexate is intended to be once a week, it's often given daily by mistake. So it may be given once a week, say, for arthritis. But oftentimes, through mistakes either of the physician writing the order or the pharmacy inputting the order and not catching the mistake, it's given daily. There have been deaths related to this and lawsuits. But that would be a good topic for the staff to sit down and talk about. In class, I often ask the students, have you ever seen a patient walk out of a pharmacy with someone else's medicines? Lots of hands go up. I think, for example, those types of real issues would be great for discussion at a staff meeting. What are we going to do about it? How can we prevent it? Everybody should have an opinion. The more we can talk about it, the better the workplace culture, I think. Recognize the good catches, discuss safety issues, and share reports of medication errors. For me personally, reading about mistakes helped me sharpen my radar, if you'd like to call it that, for being on the lookout for different types of medication errors when I was working in the hospital. The parable of the boiled frog. I don't know if you've ever heard of this, but I think it's certainly pertinent here about the workplace. As the parable goes, if you put a frog in boiling water, it'll jump out. It recognizes that it's too hot. If you put the frog in water that's cool and comfortable and gradually turn up the heat until it's boiled, the frog won't know until it's too late. What exactly does that mean? We can translate it into the workplace by saying it's important to be on the lookout for what's going on in the workplace regularly. Take the temperature of the workplace regularly. Be proactive. Don't wait until something goes wrong. The culture that waits until something goes wrong is just being reactive. We want to constantly be on the lookout. We want to be aware of the near misses. When something goes wrong, let's study it. I once saw a documentary of a CEO of a hospital administrator, rather, who, after a major mistake at the hospital, began making safety rounds. And he'd go to the different nursing units and ask, what mistake are we going to make next? In other words, what is a mistake just waiting to happen? And it generated great discussion. And again, I think this would be a great question to ask at a staff meeting. What do you think our next mistake is going to be? What can we do about it? How can we deal with it ahead of time? And in the workplace, I just already talked to you about the issue of the normal saline and sodium bicarb. It's important for everyone to speak up in the workplace. Is another moral of the story. Peter Senge wrote the book regarding the fifth discipline, and in it he said, today, the primary threats to our survival, both of our organizations and of our societies, come not from sudden events, but from slow, gradual processes. Another way to interpret that is, sudden events happen not out of the blue, but because of things that are taking place now that are not quite right. And taking the temperature of the workplace, if that becomes one of the key aspects of an organization, if that's accepted by the culture of the organization, it's more apt to prevent, something terrible to happen out of the blue. The parable of the boiled frog. Root cause analysis, as many of you know, is often a process that takes place when an error happens to investigate it. The focus is not on who made the mistake, but why and how it occurred. And there's several categories to evaluate when an error occurs. Did it involve communication, the training of the people involved, fatigue or scheduling, the environment, equipment? Speaking of equipment, there are many sad tragedies that have happened because people have used the drop-down menu in computers and selected the wrong line. A drop-down menu when preparing a TPN solution might list the units. And there have been cases where someone had selected micrograms instead of milligrams, or vice versa, and resulted in significant overdoses or underdoses. Rules and policies and system defenses, etc. But this is also part of looking at, the workplace, taking the temperature of the workplace. And these are perfect areas to talk about long before an error ever occurs, to sit down and discuss and evaluate what's going on in the community. We should have a culture within the organization that's looking at these things not after something happens, but regularly. And this is just more information with questions that are specific for each category. As we near the end of our program, I did want to talk about someone you may never have heard of before, Inspector Maurice Henry Clark. Inspector Clark was a safety officer for the British Navy. He signed off on the Titanic, saying it was okay for the Titanic to sail. Just recently, several years ago, a few years ago, some of his papers were discovered and actually auctioned off. And I want to show you, this is actually his papers. I've circled a few things. And this gets back to speaking up, culture of speaking up. In the first circle he wrote, I suggest 50% more. He was talking about adding lifeboats to the Titanic. Remember, he wrote this before it sailed. These were his notes. I suggest 50% more. Now, what does that mean? There were 20 lifeboats on the Titanic, which would have held about 57, 58 people each. 11, I think that's 78 or 48. He suggested a 50% increase, which would have made it 30 boats, or about 1,767 capacity. He wrote that the reasons were this permits of all persons being transferred to another ship. First, he wrote 2 journeys, meaning that if something ever happened and another ship was close by, the lifeboats could row to that ship and transfer the the passengers. Then he wrote, not advisable for all hands on account of the cost, upkeep, and extra manning. But he wrote, a sufficiency of boats for all hands would allay a panic. What happened was, he wrote all this down, but he was shot down by the ship owners. This is some more of his statement. To deviate from regulation, which had been drawn up by the advisory committee of ship owners and approved of by my department, would leave me without any support, meaning that he might really push his recommendations, but he would have been shot down by the ship owners. They concocted their own rules and regulations, which the Titanic met, and any effort to increase lifeboats probably would not be met with approval. And he added, insight be shifted, or I might be shifted as suggested to me by owners if I enforce my views. Meaning, he was pretty much told that if he really pushed forward with his suggestions, his position would be changed. He was threatened. Bottom line was, nothing happened, the ship sailed, and many people lost their lives. Following this, he was at a hearing, and he was nailed to the wall. The board asked him, do you think the safety check satisfactory before the Titanic disaster? And he said no. Then why did you do it? Meaning he eventually signed off on the safety inspection. Because it was a custom. Do you follow a custom because it is bad? Well, I'm a civil servant, sir, and custom guides us a good bit. Custom guides us a good bit. He had reservations, he wanted more lifeboats, but he didn't pursue it. So he signed off and said everything was okay. You know, in a workplace environment, that same philosophy often occurs. You know, if people want to change the way things are done, improve things, a dangerous thing to hear is, well, nothing here has ever happened before, so why should we change anything? Or if you've ever asked, why do we do things this way? And the answer is, we've always done things this way. I don't know. I think to me that's a red flag. We have to be willing to have an organization that's willing to, you know, look at how things are being done and perhaps change things that are necessary. Otherwise, we'll be like Maurice Henry Clark, never speaking up, letting things stay the same, and perhaps bad things can happen as a result. The best workplaces, the best workplace cultures don't happen by accident. And I think it takes all of us working together to improve the workplace, to make sure employees and staff know that they have support, to question things, to make things safer. No one should feel like that they're not supposed to question anything. Errors should be reported. No one should be afraid to talk about errors or mistakes in the workplace. Supervisory skills and management skills have an important part of a workplace culture, and in particular, a safe workplace culture. And I think we need to put more emphasis on developing those types of skills in employees, in pharmacists and technicians. I think in the academic setting, I'm not so sure how good a job we do in actually preparing people for management or supervisory positions, because these positions often occur soon after graduation. A student may not wait 10 or 15 years before they become a manager. It can happen within 6 months. But having basic supervisory skills and management skills are really critical to develop the kind of workplace culture that we need. I hope this presentation has at least provided some food for thought and maybe some things for you to discuss further. And hopefully, maybe some things to actually pursue in your workplace setting with some of the references I've provided and some of the links. In closing, I have enjoyed providing this webinar for the North Carolina Association of Pharmacists. I hope you found the content to be informative. To receive continuing education, please follow the instructions provided for this webinar on the NCAP website. Thank you so much for your participation.